So today we are going to know about interstitial lung disease. It is one of the important disease in the respiratory system, and it is often misdiagnosed as asthma or COPD. So we'll start with the case, and as we go, I'll tell you what is the importance of doing the diagnosis early. So this is a 67-year-old gentleman who came to the hospital with cough, which was dry, bothersome, and shortness of breath. These symptoms were progressing since last 6 months. The patient was ex-smoker. When we examined this gentleman, he was having bilateral velcro crepitus on the RS examination, and clubbing was present. Rest all parameters were fine. So once we hear the word smoker, most of us try to go for the diagnosis of COPD. Same thing happened with this gentleman. From last 6 months, he was on inhalers with no relief. So what did we do next? His X-ray was already done outside, which was showing mild haziness in the bilateral lower zone. I don't have an X-ray picture. We subjected this patient for a CT scan. This was the CT. As we see, there are multiple fibrotic changes peripherally, and it is extending from upper lobe to lower lobe. And also this area, what we see here, is called as honeycombing, where you can see many of the fibrotic lesions. I'll show you again the area of honeycombing. These are the areas where you see the cysts lying above each other. These are the areas where we call it as honeycombing. Coming to next, once you have seen this CT, what next you are going to do? This patient has been labeled as interstitial lung disease. So how do we approach this patient? What to do next? So first we'll do PFT, we'll see the DLCO, diffusion capacity. There are a number of tests which we can do. But what do the guidelines say? In any patients of ILD, first you see for the identify the cause, whether there is a history of connective tissue disorders, whether there are drugs or any kind of exposures. This gentleman had history of smoking. Yes, this patient who are smokers have a high propensity to go towards IPF. But we should rule out other etiologies such as CTDs, drugs, or if patient is exposed to some kind of environment like there are pigeons nearby. This one of the most important cause of ILD in India is hypersensitive pneumonitis. Then you do a CT chest. If it's UIP, you can say it is IPF. If there are other features like possible UIP, inconsistent with UIP, I'm not going to go into detail of that because that is out of purview of our webinar. Because if we speak about ILD, there are 200 types of ILDs. Then we are going for surgical lung biopsies, and we have a multidisciplinary discussions. If it is not a UIP, it is not IPF. So we have to see for the other causes. So it is very important to differentiate between idiopathic pulmonary fibrosis and the other causes of ILD. Why? Because the therapy is totally different in both of them. So first thing is that you have to diagnose whether it is IPF or not. If it is not IPF, then what it is. So you do the comprehensive evaluation, you do clinical examination, PFT will show restrictive pattern, even DLCO is done. DLCO tells about the reduction in the DLCO. DLCO is diffusion capacity of carbon monoxide that actually calculates how much gas is being diffusing through your interstitium, because ILD is a disease of interstitium. You do CT, you do serology to know about whether patient is having any kind of autoimmune disease. Then you may require bronchoscopy to rule out whether there is any infective etiology, or you have to see for any kind of like in hypersensitive pneumonitis, BAL shows lymphocytic predominance, or in eosinophilic lung disease, there are eosinophils in the BAL. So you need to know about the specific BAL characteristics in certain diseases. And biopsy, if required, you have to do biopsy in patients of ILD. So you can do either surgical lung biopsy or you can do bronchoscopic biopsy as well. Once you have all these in your hand. You subject this for multidisciplinary discussions. Get a diagnosis, well and good. You start the treatment of the patient. If it is not possible, then you try to label that patient as IPF or unclassifiable ILD, and you do serial PFTs, and which are done every 3 months to 6 months, and serial CT scans if the disease is progressing between 6 to 12 months, and then you have to see for the progression of the fibrosis. What is ILD? ILD is a disease of interstitium which actually includes, as I said, more than 200 entities. This ILD is actually classified like this. So you have ILDs where you have IFPs, that is idiopathic interstitial pneumonias, in which you have IPF. We have idiopathic non-specific interstitial pneumonia. You have RBILD, DIPs, COOP, or cryptogenic organized pneumonia, then acute interstitial pneumonias. Then you have idiopathic lymphoid interstitial pneumonia, idiopathic pleuroparenchymal fibroelastosis, and you have unclassifiable IFPs. Whereas this you are calling it as idiopathic because you don't know the exact cause. Then you have autoimmune ILDs. So in autoimmune ILDs, again, it is divided into two types where you are able to know about the which disease, autoimmune disease patient is having, like rheumatoid arthritis, Sjogren's, SLEs, polymyositis, dermatomyositis. Then you have mixed connective tissue disorder ILD, systemic sclerosis ILD, other connective tissues which are associated with ILDs like dermatomyositis, polymyositis. Then you have interstitial pneumonia with autoimmune features. These are again a gray zone where these pneumonias are actually having features of autoimmune diseases, but it doesn't come and fit under complete diagnosis of ILDs. Then we have hypersensitive pneumonitis. This is one of the most important cause of ILD in India presently. The registry shows that. Then we have sarcoidosis. Then other ILDs which are rare, like lymphangioliomyomatosis. Then we have Langerhans histiocytosis, drug-induced ILDs, ILD because of other exposures, then vasculitis, granulomatous ILDs, and very other rare ILDs. What happens in ILD? What is pathophysiology? So, in our alveolar structure, whenever there is some kind of endogenous or environmental insult, this causes your degradation of these cells, and once there is degeneration, there is tissue regeneration, but sometimes there is aberrant repair because either there is some kind of insult which is already endogenously present, or there is some kind of genetic defect which causes aberrant repair, and this causes increase in the thickness of the interstitium called as interstitial thickening or interstitial fibrosis, which happens later on. So what happens? Susceptible patients, susceptible individuals, repetitive micro-injuries, environmental, virus, comorbid conditions. Once you have onset of symptoms, there are multiple acute exacerbations. This is the natural history of disease where patient goes to fatal respiratory failure. But if there are acute exacerbations in between, these patients succumb very sooner than the normal natural history. What do? We try to prolong the duration between the exacerbation by various measures.